my pleasure to introduce to you Mr. Richard Bergstrom, EFPIA Director General, the plenary Ecosystems for Investments and Innovation. What have we learned?
So, thank you very much. Good eftermiddag. I suspect we have some Scandinavians also in the audience. I will not speak my native Swedish, but in English. I hope you're grateful for that. Very happy to be here. I have been asked to reflect and make also some personal reflections on what we have learned about ecosystems in life science. I represent EFPIA. EFPIA is the European Association for the Research-Based Pharmaceutical Industry. So sometimes we refer to as big pharma. We also have smaller companies in our membership, but basically most of the pharmaceutical industry is part of my association. Before that I lived in Sweden and I was running the association in Sweden. I will talk about what I will not talk about, what have we learned. I'm going to share a few case studies with you and then draw some conclusions. But first, let me say this. I realize I probably speak to the converted already, because you came to this meeting, you're so interested in life science and innovation. But something that I have learned in my job, and particularly when I travel in this region for some reason, that innovation means different things to different people. There are still many people, and senior people, that think of innovation as roads, gas pipelines, airports, factories, shiny factories. That's a part of it, of course. That factory will be there to produce something. So when I speak to other audiences, I spend some time describing why do we need to do research in life science? Why do we need to have medicine, to develop new medicines? We're not ready. It's not enough with the medicines we have. We should not take that for granted. Not everyone understands that the medical progress is not coming by itself. It has to be nurtured, it has to be stimulated. Someone has to pay for that innovation, and so on. And I hope that all of you in this room are with me on knowing that why is it that we're interested in investing in life science research and innovation. Why is that? Well, again, it's obvious for you. It's that medical progress, being medicines or devices or imaging, everything you do, is of value for patients because it makes them live longer or have a better life, healthier life. There is a more crude economic argument, and that is that if we stay productive, we can contribute to the economy. As you all are aware of the debate in Europe in the financial crisis and everything, in the long run we know that our commitment to our citizens, the welfare model of Europe, is actually not that sustainable because we have too few people working. We don't allow immigration anymore, we're not making any children, and we want to retire at 55. Plus that we actually ask for more all the time. We want the best. We have very demanding patients. And we do live longer, which means that we're going to consume those pensions and that healthcare for longer. So it's actually the best allies we can get in this debate is from the economists, the macroeconomists that care about healthy aging, active and healthy aging. We can add a number of years of productivity to our lives, healthy life years, and contribute to the economy. That may save the European model. Now that was maybe a little bit deep, but it's profound. Then of course, and maybe that's the most tangible output in the short run, is that it's economic activity, it's jobs, it's exports, it's revenues, and that's also what makes our economies go round and pay for those pensions and pay for the healthcare. So, what have we learned? I'll share a few examples with you from my experience. I have been 20 years about or more in the pharmaceutical industry in different jobs internationally. Started working with the Swedish government actually, the regulatory agency. So this will be a few examples from particularly the last few years. first exhibit I want to show to you, I could have brought the book, but I didn't. We did a report in Sweden. When I was in Sweden, I was part of the government commission that looked at life science and happens boost research. And we commissioned work, there was a book published called Tre stora, tre små. That means 3 big ones, 3 small ones. So there were some experts that analyzed 3 big countries and 3 small countries and their attempts to attract and build a life science industry. And it was interesting because, and I'll simplify to make the point. I'm not sure I give full credit to the full review of these reports, but they singled out 2 countries to be interesting to look at. One was Ireland and another was Finland. Ireland has been very successful in attracting a biotech industry for production, advanced manufacturing. So biotech, there's I don't know how many there are, but there are 24 at least very sophisticated manufacturing sites on the west coast of Ireland, contributing an enormous amount of money to the Irish economy. How did that happen? Well, simply put, combination of 2 things. Low taxes, and always compete with taxes, but maybe more important for our discussion is that there was a deliberate plan from the Irish government to attract. You know, you remember the Celtic tiger, remember that? In that era when Ireland was really growing, they decided to invest strategically in some industries, and this is one industry they wanted. So they invested in education, they made sure that they churned out, this is in the west coast of Ireland, so it's really in rural areas. They managed to have enough of engineers, enough of laboratory staff, all these things. They invested in infrastructure like water and wastewater management, all these things to attract industry. And the investments came, and the companies have stayed, and they actually upheld the investments and reinvested in them, and it's a success story. Now then what did the Irish government want? Well, the plan from the beginning, which I didn't know until I read this book, was to start with the manufacturing and thinking that then the rest of the industry will come. You know, there's manufacturing, but there's also the sort of more upstream or downstream, you can say, is the research. So the research, the preclinical, clinical research, which is actually, you can argue, it's no export really, because you don't export goods, so it doesn't really show up in the export numbers, but it's jobs, lots of good jobs, high quality jobs. And there they failed, Ireland failed. And the conclusion, at least by these authors, was that, well, that's because they didn't have the academic research. The best Irish doctors and researchers, they left Ireland. They leave after medical school or pharmacy school. They go to London, or Cambridge, or go to the US. So, and the hospital, the university hospital quality was not the best either. So they didn't manage to get, they managed to get a factory from Pfizer, they didn't manage to get their R&D investment from Pfizer. So there's a learning there, is that there is one logic for manufacturing, and there's another logic for the other type of research. Now, the other example was Finland, where Finland, when the Berlin Wall came down, the Finnish economy tumbled because they were so heavily reliant on exports to former Soviet Union. And there was the GDP shrunk, I can't remember what the figure was, there was someone that knows that. But there were a very ambitious program from the Finnish government to try and find alternative sectors to live on, not only forestry and mining and so on. They managed very well to retain shipping, with the wars. Nokia is a success story. It's been a bit trouble lately, but nevertheless. They tried with life science. Not with great success. I hope I'm not offending any Finnish colleagues. There's a lot of interesting activities right now, it's still in Finland. But if you look at the ambition, that's the important thing. The ambition was to really replicate what was done across the waters in Stockholm, Uppsala, and what was done particularly in the Öresund region. And that, I hope you all agree with me, that did not work. Okay? So that was just slightly, I remember these authors saying that, it was just too ambitious. And the way they described it was that there was a sentiment among Finnish politicians that they said, okay, here's a green field. Here we want a life science industry. And as long as you put X billion on the table, you can build it. These authors concluded the reason why that didn't happen was that they didn't have a strong history. They had Orion, which is still a very successful company. But that's all they had. They didn't have a Novo Nordisk, they didn't have an AstraZeneca, they didn't have a Pharmacia. They didn't have, like in the UK, AstraZeneca or GSK. They didn't have the big pharma, they didn't have the mid-sized pharma. They didn't have this thing. And maybe on the academic side, it wasn't that. Tech transfer and commercialization maybe wasn't as sophisticated in the Helsinki or in Turku region at that time. This is what they said. Things have probably changed since then. But it's an interesting learning on, real field is difficult to do. Okay. So, another case study, personal experience. When I lived in Sweden, I was often traveling together with our ministers on various trade promotion trips and so on. And I went with our health minister, still there, John England. We went to Dubai once. It's a big Swedish delegation. There were companies that wanted to promote exports, but it was also a question of investments, attracting investments from them. They got some money to Sweden and clusters in Sweden, so it was both ways. And we visited Dubai Health City. Dubai Health City. This was before the Lehman Brothers crash, so still there was a lot of booming in Dubai. At that time, it was said that a third of all the world's cranes, building cranes, were in Dubai, and that was true. I could see them all. Now it's back again, actually, after the downturn in 2008. But when we visited the Dubai Health City, we met with the Minister of Health for the Emirates, and he described what we're doing. There was a model there, and there's like, I don't know how many acres it was, and it was like the Karinska that I knew was dwarfed by their investments. And he described how they're investing in healthcare, in hospitals, high-tech hospitals, research and education. And then someone asked the question, because they wanted to export healthcare. They wanted to have tourism, medical tourism. And they showed us a map, and they said, here's Dubai in the middle, we have these great airlines, great airport. Within this region of 3-4 hours flight time, we have all these, whatever, 1 billion people or 2 billion people, and lots of them with lots of money. So they said, we want them to come here for their annual checkup or for their surgery and so on, this planned elective care, and they should come here. Good business idea, model, and they're onto it. But then someone asked, so, but what about the research? What is that going to do with it, with the education? I said, no, we've studied this, they said. We benchmarked Boston and Stanford, Palo Alto. We looked at it, used them. And what is it? How do we get the best healthcare in the world? Because we compete with quality. How do we get that? Well, we need the best people. And how do we get the best people? Well, these people that we want to attract, they want to do research as well. Interesting. So their idea was that they would get the best cancer guys from MD Anderson Hospital in the US to come and spend a week, a month in Dubai to see patients, do surgery, whatever they do, and at the same time have a little research team there. So there'll be 10 PhDs churning out research at the same time. That's the thing that would be attractive in this competition for skills, particularly in the medical profession. Very interesting analysis. Same thing with teaching, that many of these people like to teach. They want to have students, they want to find the best people to take on board in the research. So that's why they said, that's why we need a medical school as well. So they didn't just build a hospital for producing healthcare, they built a university hospital and university in this health city. Very interesting. It tells you that it's all interconnected. Similarly to that, I'll give you the third case study from my personal book, is from Sweden when I was on this board of the Karolinska Institute, which is the university side of Karolinska. There's also the hospital side. And we had, from the university side, we've been struggling with the fact that the hospital, I'm sure there's someone from Stockholm here, hospital was only concentrating on cutting the waiting times and the queues of production. Production. Physicians that wanted to do research on the side, whether it was translation or preclinical research or clinical research, that was not stimulated. Actually, it was actively not promoted by several of the middle-ranking persons in the hospital. And we were so frustrated from the university side that the hospital didn't prioritize research, because this is all interlinked. Until one day, when the central government in Sweden, in the prioritization work, decided that we would not do any, we could not do more, could not continue to do cardiac transplantations in Stockholm, because we should only have one site in Sweden, and that would be Gothenburg. And in the ratings, Karolinska had not full points on, guess what, research in the hospital. Then they woke up, the politicians woke up and said, oh, this is corrected. Yes, thank you. Now, this was 2 years ago. I hope someone from Stockholm can say things are better, I don't know. But this is a long debate in Sweden, you know. Why is it that the universities are state-run and with one accountability, one metric, one motivation? And then there is the hospitals that are only there to produce and actually reporting to our regional authorities, which are elected, locally elected, the landsting. So this tells us a story about that you need to all be somehow sharing the same vision, and you are measuring your people, you're motivating your people. I had an interesting lunch conversation with your Vice Minister for Economy about this. This was his first question: how do you motivate people to do all this? And he was zooming right into the right question. It's about that. So you need to motivate, you need to measure, reward people based on that. So hospitals must be measured on not only on producing healthcare and with quality. They also need to be measured on education, that the fact they contribute in education, and they need to be measured on doing research. And research is then defined, I think, not only as churning out publications or number of PhDs, but actually also commercializing or seeking to commercialize, or seeking to actually that the research delivers real products and real interventions. And this is something that I will come back to. So with these case studies, I think I've just, in a very simple way, I think illustrated to you that the ecosystem for life science has these legs of research, of education, of healthcare production, if I call it that. And then, of course, it's the industry, it's the private sector. And anyone who wants to stimulate this or attract this has to understand that you need to have all these components somehow. And if your one is weak, then you need to stimulate that. And they all need to be in harmony, and they all need to go in the same direction. I also mentioned to the Vice Minister over lunch that another really good example of how to do this is Boston, of course, where, just as an example, every week the governor hosts a meeting between the head of the MIT, the head of the hospitals, the head of the big companies, everyone, just to say, okay, is everything fine? Everything working? Any problems? To make sure that if there's a problem, it will be fixed. If, you know, the one university is saying that we're going to reduce the number of persons that we educate for this, and the company can say, wait, that's exactly the type of category I need to hire 5 years from now. Don't reduce the number of students on that. Oh, okay, good. That's good feedback. So a lot can be done without money, actually, just by talking to one another. So after these case studies, let me point out to you some crucial components in the ecosystem. And one is clinical trials. Clinical trials, if you're familiar with those, are in the later stages of drug development. Once you're onto something, you have a target, you have an asset, a molecule, or whatever you have, and you start your development. You usually start in animals. You have to start in animals. You have some models. You start with healthy volunteers to see the test that you get the doses are safe and so on. And then when you get into real patients, that's when we have real clinical trials. We call them phase 2 and phase 3 trials before approval. This is a big business. In Europe, it's 30 billion euros. There's a lot of money, and it's good money, because this money goes straight into hospitals. It pays for the time that doctors spend, nurses spend. It pays for staff in my industry, in CROs, these contract research organizations. It pays for monitors, it pays for training, it pays for traveling, because these people have to have the latest knowledge so they can go to congresses. There's a lot of benefit from this, and then the indirect economic activity. The clinical research is actually quite, it's global. It can move. It's not a building. And a country can actually attract, in just a few years, can establish itself as a player. And similarly, you can establish yourself as a non-player, and you can lose it. And some countries around Europe are facing that right now, that we're losing out. And why is that? There are many trials that go to this part of Europe. Initially, it was driven very much by cost, but also by enthusiasm. There were lots of very enthusiastic doctors in the new member states that really wanted to do this, and were eager, and they were maybe more keen to deliver on time, because you need to recruit patients. That's a term. You recruit patients to these trials. You ask them whether they want to take part, and you have to deliver on time, because it's all the time, all the chase. We have a patent time in the industry, and that patent time is limited. And the more time you spend developing things, the less time you have to make money, simply put. So competition in clinical trials is about cost, yes, but quality, commitment, that you have the patients. And this is something that is at the center of any life science strategy. Unless you simply go, and not simply, I don't want to be derogatory in any way. You can have an Irish strategy and say you want manufacturing. That's fine. That's absolutely fine. And the more of that we have in Europe, the better. But if you want to go for this broader system, which includes the universities and the research, and have your own companies and startups and spin-offs and all these things, then you need to think through the rest of it. And then clinical research is at the core of this. It's at the absolute core. And to get that going, again, you need to measure the hospitals. You need to reward and motivate individuals to do this. There should be a gold star if you manage to attract a clinical trial and you complete it on time. University hospitals can help with maybe having administrative support for getting going. Also, if you want to do your own trials with public money that you get from funds and not from the industry. It's important that these clinics are up to date. Of course, I work with a research-based industry, so I am biased. And I want to hide that when I'm trying to sell something to you. It's very important that these hospitals use all the latest products. Because no one wants to work in a clinic which is 20 years behind. You know, you need to select the patients because maybe they have tried something before and failed. Very often the new medicines we develop are not for new patients. They're for patients where the cheap generics don't work. We have a lot of good medicines. We all develop them. And they're inexpensive, but they're just simply not sufficient. So in this environment, in this ecosystem for clinical research, you need to have the latest knowledge and access to the latest medicines and technologies. So you need to have the latest devices, you need to have the latest. You will look pretty, it will look embarrassing if when the international research team comes in and they find out that, you don't have the standards, the appropriate standards. So I think this is a very important observation. Then the thing with clinical trials, why it's somehow a way into this is because you may start with a phase 2 or a phase 3, but then that results in post-approval studies. If you listen to Guido Rasi from the EMA this morning, I didn't hear that, but he told me that he spoke about this. You will hear how the whole development paradigm is changing. We're moving much more to also doing studies in what we call real life to evaluate effectiveness and subgroups and validate whether the clinical trial results are okay. So we're looking much more at phase 4 trial, post-marketing systems, observational studies. So one thing leads to another. So if you've been involved in phase 3, you're probably going to be involved down the line as well. And it's also and it goes the other way too, because what we see is that with the type of scientific developments we have now, and I'll come back to that, and you know the term translational medicine, which is about trying to make any sense of all these omics and make something out of it. It means that the clinical research franchise has to be much more integrated in the preclinical and even in the earlier in the lab work, in identifying what patients they have and not. It's like a colleague of mine told me that in the old days when we did clinical trials, well, not still present, when we do clinical trials, we go to a doctor in, let's say, Vilnius, and we say, do you have 30 patients like this? And they'll find them. Now, with the targeted drug developments we're looking at now, it could be that we need 500 patients across Europe, but not a single center has more than 1 or 2 or 3. Either because it's a rare disease, or because it's a particular type of Parkinson, or a particular type of diabetes or something, once we know what's causing the diseases. So it could very well be that it's a patient organization, or it's a community on Facebook, a group on Facebook with people suffering from the same disease that actually becomes the recruitment ground for the industry. So the clinical research is both upstream and downstream a way to attract investments and interest in life science. The other observation, key observation I want to share with you is that things are in flux in a way. I mean, we have changes in science and we have changes in the industry, or in the private sector, if I call it that, industry big and small. First, on the scientific side, I'm sure you've noted that just in the last few months there have been at least 3 breakthrough publications. It's not one publication, it's a whole book of publications that's come through. That we need to sort of just reflect on what this means. One was a few months ago when they announced a research group led from NIH, as what's very common. They announced that they have now managed to map the connectome, which is the wiring of the brain. We haven't really known, right? I mean, you know, a neuron is pretty small, you know that. But did you know that it's actually usually a meter long? So it's connected. So we're talking trillions of connectors between neurons. And this we haven't had no map of. So we know perfectly well about synapses and substances, and we in the industry we can find things that block and promote and various receptors. But the electricity connectors, we haven't really been looking so much at. Now we have this map. Thanks to new technology, computational, the computers we have, the imaging we have, the tools we have this. We have the map. So now the work starts. And it was interesting, I read that one of my companies, GSK, announced a few weeks ago that they're now going to start a research franchise in nanoengineering. They're actually thinking about electrical engineering in the brain. Because think about it, it could be that there's some connectors that are simply not working. It's very tiny. So there's a whole new field that's opening up. I want to thrill you a little bit with that. The other one which came through was the mapping of all the bacteria that we carry on us. The microbiome. The 3-4 kilos of bacteria we carry. Most of it in the gut. Now we know who they are, these creatures. And we need them, many of them we need. And what they do and how they interplay with man, how maybe allergy could be because of, you know, another type of flora or fauna than others. All sorts of interesting theories and opportunities that open up. Another third one was last week when we read that junk DNA was not junk DNA. I think many of us, having studied genetics a bit, we knew that all the time somehow, that it can't be that. Nature can't be that stupid that we have non-coding elements which cost a lot to replicate and is useless. Now, of course, all the regulation mechanisms are somewhere. And so, you know, we map the genome, that's fine, but we don't know how it's controlled. Now we have a map for that. So now we can begin. I think I and others in the industry, and when I listen to my research colleagues, they are so excited. I've never seen my discovery people in this being so excited. On the one hand, so excited about the opportunities, and at the same time so frustrated with the fact that it takes so long to develop, it's so difficult to develop. We have these regulators that have high demands, and then no one wants to pay for the medicines. Okay, sorry, I have to bend that a little bit. So the scientific landscape is changing. Definition of disease will look quite different. We think Parkinson is one disease just because we give L-dopa to people and it sort of works in the beginning. No, it's probably at least 6-7 different causes. Genetic or not, up or down regulation of genes, I don't know. But once we get to develop the next wave of Parkinson medicines, they're going to be targeted. You've heard about personalized medicine. This is coming. It's coming big time. But it's like, you know, when the internet came and, you know, we thought, well, you know, we have the internet, we had this for a year, it didn't change much, did it? But look now, 20 years after. It's the same thing with this. The omics will fundamentally change the nature of research and the nature of healthcare. And of course, we are sort of adapting to this as an industry, so we're changing too. We have to change with this science. And I'm very happy to see that tomorrow we have organized together here our industry association and the partners have organized a session on IMI. This is the Innovative Medicines Initiative, a €2 billion partnership between the European Commission and my member companies, which was conceived a few years back by some very smart people that realized that all this will happen. We're going to get this genome mapping, we're going to get all these things, and we simply have to collaborate. The companies have to collaborate with it, and we need to collaborate with academia in a whole different way. It can't be that one company works on this, we go and talk to that academic group, and we sign secrecy agreements, confidentiality, and we work, and we spend 10 years on this, and then we fail. And we don't learn from that group who work with another company with a secrecy agreement. It doesn't work. So in some fields of research, we simply have to just pool everything we have. We still own our patents. We will still have what we bring into this, and we will still make money on that. But if we come up with something in collaboration, we'll share it together. This is not fundamentally changing the business model of the industry. Our business model is that we patent things, we get exclusivity, we sell, we need to have a fair price, and then the patent goes off, and then it's boom down, price falls. That's fine. That will not change, fundamentally change. But we can boost productivity of everyone by working together. So IMI, and we will know tomorrow, is companies going together saying we would like to work on this. It's an invitation to academic groups and SMEs to come in. There's money from the Commission to academia and to the SMEs. Industry contributes with in-kind resources. We're now working on the next IMI under Horizon 2020, which is the next framework program starting 2014. And this will be bigger than IMI, maybe 50% bigger than IMI. And we will have even greater flexibilities in that. So industry is responding both by collaborating more with one another, both with academia, with one another. They're endless. I can spend the whole afternoon just going through all the various deals that have been made, either between my companies and smaller firms either buying small companies or just buying rights to compounds. You have examples where companies go together. For instance, Pfizer and GSK, they merged their HIV franchises and research in a company called VIV to be more productive and effective. One of my CEOs, Chris Wiebacher from Sanofi, said something quite controversial some time ago, and it was quoted in the Harvard Business Review, and there were even case studies on this and what did he mean and so on. He said this: the best people in life science research are no longer in the companies. I wonder what the employees will say. But he said something interesting. He said that, listen, we need to keep up with all this latest thinking. And the industry therefore has to transform itself from having been a one house with everything in it. Everything. And to realize that that is an ecosystem in itself. That we surround ourselves with startups, spin-offs. We let maybe our own managers, executives basically walk away with the project. If we don't want to continue with the project, we offer them, you can take this, you can get it. We want royalties back. If you take this, and maybe we give you some start money, you can go and get risk capital if you can. Good luck. It doesn't work, you welcome back. Still like you. That works, and we've seen numerous examples. I have many colleagues, many former colleagues that have done exactly that. So the fundamental business model is the same, but the way it's executed will vary increasingly. In GSK, they decentralized the drug discovery into very independent units and let them sort of compete with one another and even go and ask for money outside and so on. So some companies see themselves more as investment houses, if you want. There's some core competencies they will have internally. Core competencies in maybe how to do clinical research, regulatory, how to get things together, how to package everything, how to get the right data for the payers, the HTA, Health Technology Assessment. They will say, is this worth anything? So this knowledge, this fundamental knowledge about what the markets are and what they need with how you develop medicines, that is a competency which is still there in big pharma, and companies still retain manufacturing to a large extent. That's strategic, particularly advanced manufacturing. You retain competency on patenting and so on, whereas you may outsource. I think as much as a third of the clinical research is outsourced in Europe. Manufacturing, some manufacturing is outsourced. So the industry is sort of moving with the times, if you want. And one needs to be aware of that. This is a fantastic opportunity for countries like Lithuania and others in the region that are actually looking for partnership. Is that those days are gone, and you realize this, when a buyer or a BMS will say, we're going to build a research site and hire 500 people. And you try and have it built here, across the road here. It doesn't work that way. The way it works is that if you want that to happen theoretically, then you have to start here with the universities and the research and the skills, the brains, and you create that, and then one thing will lead to another. But I think actually one should not have as objective to have a building with 500 people in it. That is not the system of innovation. That is not the modern ecosystem for drug discovery. It's not. No, it's this, I hate clusterize and misuse word, but it's still valid. It's create that environment where these international players, not only big pharma, it's also NIH, it's Gates Foundation, it's the Wellcome Trust, it's the R.W. Johnson Foundation. It's a lot of private money around from other sources as well. And this is global capital, it's global ideas, global brains, and how do you anchor that in a country or a region? That's how to think about it, not as building physical buildings. Innovation is more than that building, remember I said that. The markets are also changing. Guido Rassi, I think, alluded to that. That it's not enough any longer to say, okay, I have a patent, I have a new molecule, I've changed the chlorine atom to fluoride. It's new, it's patented, and it works in animals, and it works lower blood pressure X. Forget it. Can't sell that. Because there are all these drugs available that also lower blood pressure X. You have to show added value. You have to show added value for some patients. I tell you, this sounds easy, it's a real struggle. The industry has over the last 10 years really transformed itself with its pipelines, with its packages, the data packages. Every company works on this, market access. You have to have your value proposition, your value dossier. You put together all these arguments for where this should be used. But I share with you our frustration that many of these people that do assess this are either only there to cut the budget, or they are not close enough maybe to the clinics to realize that there are patients that really will benefit. And then there is the element that maybe they don't trust us, that we will only market it for those that it was approved for. So it adds value for you, not for them over here. So I want to sell it only to you. Now traditionally, maybe we didn't care so much about being targeted. Now the industry wholeheartedly knows that we have to target that in order to get value for money, otherwise we'll be kicked out. And there's also from payers not the trust in doctors either, for that sake. And they think that we are whining and dining together, which is why that has to stop. So, we have a challenge on the market side. And recent research, and I'll make my last point, so I'll kind of try and keep the timelines of the program. My last point is the importance of the demand side in the innovation system. If you follow this, and I know we have experts in the room, but if you follow the actually more academic and empirical research in this field, it's clear that the demand side plays a role. So it's not only that you have the brains, money, ideas, and then it works. You have to have someone down the line who's actually absorbing it and ultimately paying for it. And the demand side to me is both the regulatory framework and the people that use and pay. We need to have regulators that are interested in innovation. Now fortunately with the European Medicines Agency, with EMA, with Guido Rassi, and also with the FDA, they are interested. They know that we're not done yet. We need new medicines, and we need to have the right balance. And we can work with them. You know, we don't like their decisions all the time, but we respect the regulators and they respect us. And it's not by chance that the countries in Europe or regions in Europe that have been successful in life science have also been tightly regulated. Think about that for a second. You do high quality clinical trials, you do high quality manufacturing, no slopping. There's so many things. I've done due diligence many times when I work in companies, looking at in-licensing, and there's so many companies that get it wrong because they don't have the right quality from the beginning. They didn't have the right batch analysis, or they didn't follow the specifications, they tested the wrong batch and you can't draw the conclusions. All this is precision, which is needed. to be successful in the end. That comes with scrutiny. So the FDA, even though we complain about them, has been extremely helpful for the US industry, because they weed out people that are of low quality. They really spar, like in boxing, you know, sparring partner. So when regulators see themselves as that, that's helpful. Unfortunately, many of the payers don't see it they have a role as that. They don't want to talk to us, they don't give advice when we ask, so if you want to, do you want any new diabetic medicines? Do you want any new things? We ask them. Are you willing to pay for this? Is it worth doing any more new insulins? Should we do that or not? The doctors say we should have a new generation of insulins. What do you think? And some payers say, oh, it's not my responsibility. You know, you develop if you want, and then if you show value, maybe I'll say yes. That's not good enough for us. So a constructive approach to engaging the payer is what we need. Then you have, well-known payers. If you want to support innovation, you should use innovation. That's pretty simple, isn't it? Can you expect that the global capital, the global minds in life science would continue to stay or come to a country or place where there's no interest in innovation, in using it? Basically, we have enough. We don't need any more medicines. We have to save now. No medicines, no devices, nothing. We have no money for this. You do that. What's going to happen after 2, 3, 4, 5, 6, 7, 8 years? Are these people still going to be there? Are we going to have the motivation from the capital markets, from the individuals? I think many of the people have left to Boston by then. And my industry, when we look at where we retain our investments, maybe we'd rather, you know, retain something in Singapore or build something in Singapore than to do it here. So this is probably more a message to people next door, the Minister of Health and his colleagues, about taking on innovation. I think it's the is better today than it was maybe 2 years ago in terms of uptake of innovation. There's still some work to do. So, and interesting, if I make an analogy, is it a surprise that Germany is so successful with cars? Is that surprising? I mean, autobahns, free speed. I'm not suggesting that you should have free speed for medicines, basically, you know, free price and free volumes. I'm not suggesting that, but somehow there are, in the literature, there are a number of examples, studies, on where you can actually see the direct link, even in a country, between the markets in the country. I hate to use the term home market because that's not my point. It's not my point that Lithuania has to use new medicines to support its industry. That's not my point. But somehow there must be a recognition and understanding that the demand side in the system is important. And this is maybe more for the European Commission to think about in their policy making. So to conclude, and being very focused on being here now also in this country, you need to build on strengths. You need to carefully analyze what you have and what you can leverage. This is not a greenfield operation. Academia is key, absolutely key. If you don't have a medic, I met with the health minister of Cyprus. They're running the EU presidency now, so I met him. And he has a scientific background, so we talked about all these things. And he said, did you know this, Richard, that Cyprus is the only EU member state that doesn't have a medical school? We send everyone to London, England. Of course we're not going to get any life science research in this country. So he realized that. So his first priority, he became health minister only 6 months or a year ago. He said, we need a medical school. So, right, so he started that, and once he gets going with that, then he can attract maybe people from abroad, and he can get going. So you need to do that analysis. The academia is absolutely key in this. This is not simply about clusters or incubators. I mean, incubate, what are you going to incubate? You're going to incubate things that come from academia, right? So I think that's maybe obvious for all. But you do need seed capital, you need to have funding, you need to have infrastructure support for small companies. There's a lot to learn from clusters, from what's been done in the Öresund region, Silicon Valley, you're familiar with, and the academy there. Stockholm, Uppsala, of course, Erasmus around Rotterdam, Amsterdam, Leiden University. There is a number of places where there's a clear experience of how you build the various building blocks. It's not just one thing you need, there's not one magic bullet here. And I think you need to have the big companies, international companies, as in the big ones and the small ones, but the small ones that work internationally. You need to attract them, you need to make them so interested. The clinical research opportunity and the IMI projects, where you get in bed, if you excuse my language, get in bed with international players in a small scale. That's how you get going. And I think through these collaborations, you will show that this is a home for innovation. The president of EFPIA, who's the CEO of GlaxoSmithKline, he talks about that Europe needs to be a home for innovation. And I think there's really something to it. It's not just a catchy slogan. I think there's something to it. He said that we need to feel at home here. That's how we get investments. That's how we get it. You feel welcome. You feel welcome by the healthcare system, by the hospitals, by the academics, by the politicians. I think that's very important, to build a home for innovation. And from that will follow all the things I talked about. Good medicines for patients, but also good jobs and exports for the country. So with that I finish. Thank you very much. I don't know if it's foreseen that I can take some questions. I don't know where the organizers are, but I guess I was so good with time that I will make an executive decision and allow myself to take 1 or 2 questions or comments. If someone wants to disagree with me on Finland or something, you're more than welcome.
Thank you for your presentation. I was so surprised because you are from Sweden, because I was living 1 year there, and from Spain, that I realized that Sweden is going through of this equal system that you are been talking about. Yes, you have been talking about that the equal system is going through some important European countries like Germany, but you have talked about in Lithuania too. But how about the other Baltic countries? How do you feel about how is going through the Baltic countries to get this equal system? How these Baltic countries are working for better education, better academic system, better collaboration between international companies? How do you see this environment, this move?
Okay, that's a very good question. It's also a difficult one to answer because it's a topic on its own, it's a speech on its own. I think I have to probably say obvious things to you. I mean, the view, Ministry of Finance is key, and not the Ministry of Finance. The people with the money, they're key, of course, and their attitude and understanding of what is education and what is healthcare. In our case, education system is important for all sectors, all industries. You need to see education as strategic and higher education as strategic. Because if you aspire for growth and jobs and high-value sectors, you need to invest in education. So education is not just a cost, it's an investment. But we have a selling job to do in many places. So that is what I discovered when I traveled in this region, is that I discovered that the attitude towards education is not always, this understanding. If you want life science, you also have to figure out your healthcare. Because the quality of your healthcare, as I said, you need to be tip-top with your healthcare. You have to have the best. And you need to identify the best. So when you have very good researchers, surgeons and groups, you support them, you build the R&D around that and make sure that they have resources for research. What I have been struck with not so much maybe in the Baltic region, but particularly in Central East Europe, the new member states, if I call it that, is the lack of trust often between the public side and the private side. For historical reasons and for behavioral reasons. That's why I'm so happy that my member companies working here in this country are really trying to stick to our high ethical standards, and there are others that don't. We cannot have a perception that when my companies do clinical research, that then they say, oh, you're bribing the doctors. There's a huge difference between a wine and dining trip to somewhere and doing clinical research. And when doctors even make money on contributing in research, it's absolutely fine. But we need to clean up this mess. to make sure that we can restore trust. So that's typical for, and an extreme example is Poland, where it's very difficult to get going with clinical research and collaboration because there's this, they think it's bribery. The general public sees it as negative that there's clinical research coming to Poland. It's a very scary press reports in Poland. And then it's the thing I alluded to, just to finish, is that you somehow need to have policies that point to that, yes, the hospitals are also responsible for this. You have a responsibility also for education and research, and you have to tell the universities that they also have a responsibility for trying to commercialize things. You need to have the tech transfer of the system, the different models of that. And these things are missing. So it's not only money, it's policies. And in many places, in many of these countries, the policies are not there because innovation is defined as the airports and the roads, and not research that leads to companies and jobs and exports and so on. So it's back to what I started with. It's the notion of innovation and how innovation is at the core of competitiveness. It's very, you should try Michael Porter here. It's going to cost you a bit, but he could teach a few people about competitiveness of nations and regions where innovation is at the core of this. I'm sorry if I'm preaching, but it was a good question, and I hope maybe we can talk a bit more afterwards. Now there's time for one more question here, and then I think I need to, because the program says I should finish.
This is a wonderful talk, the Bergstrom, and I actually have two questions, but hopefully we can answer them quickly. The first one relates to clinical trials. As we know, a great majority, overwhelming majority of clinical trials fail in humans. What are steps that are being made for potentially using primates for these trials before they move into humans? So this is the first question. And the second one is, I think I was in Dubai about the same time when you were there, probably 2006. And what I gathered from your case study is that, sure, interconnectedness is very important, but toward the end of your talk you said, well, it's not right to build a building and say you're going to import all these people. So of course they can buy MD Anderson Hospital because MD Anderson Hospital is a Methodist hospital, is there for sale in the entire hospital. But the climate in Dubai is also weird. And so that is going to probably limit who they can attract. So my question is really, can you follow up maybe on how well that Health City is doing 6 years later?
I'd like to go back actually, because I have the same question. How successful are they on the healthcare ambition, on exports, and on the medical tourism? I'm sure that works, but the other bit, let's see. I think just to clarify one thing when I said the buildings. I didn't mean that buildings are not relevant, they're very relevant. Because if you have all these, you can actually do a lot by providing the infrastructure for startups and others, you all know that. So, but it's just that the idea that a company would build a building and fill it with researchers that would work for one company with hundreds of people. That kind of not happening anymore. It's much more diverse and virtual, if you wish. Now the question of clinical trials, I'm not sure that the majority of clinical trials fail. I'm not sure about that. Of course, it's a problem when you have negative phase 3 results or disappointing phase 3 results, and it's not always that it's black or white. You may actually have other trials, and all taken together, you still conclude that it's actually working and it's safe. I think the whole question of primates is extremely sensitive. You know, in fact, in a number of European countries, it's either pending legislation or already in place, is that the European sentiment is that we don't want any animal research. Italy has just forbidden the breeding of dogs and Italy was the biggest source for dogs for animal research. And there was one breeding farm which was just closed last week, and they had like 1,000 beagle dogs, and they were basically just let out to the population. You can have a dog if you want. So first, you need to ask the question to a real scientist. I'm half one. pharmacist. But I don't think strategically, and I have not heard anyone really speak warmly about increased use of primates in order to have better precision in clinical trials. Maybe I missed some debate here. I'm happy if you want to tell me afterwards, you know, if there's some debate that I missed out on. I think we increasingly have to realize that, you know, we should minimize animal research to the extent we can. And there are other techniques and options that we have to. Well, that the public sentiment is very clear. We have to defend. You know, what we have, and we have to say it's always going to be a necessity. We can't get away from it. We always have to have this. But the notion that there are research pathways which will require us to go down to even more animal research, particularly in primates, I just would find that very troubling. Now, I'm a policy person, so of course I'm very sensitive to the sentiment and the politics and the media and so on. But if the scientific community believes that that's the right way to go, then we have a real uphill battle, I tell you. But I'm very happy to talk to you in the break about this, because I may have to be educated. Now, okay, one absolutely final one. Okay, there was one at the back also.
One last remark, if I may. First, I enjoyed very much the fact that you say one of my CEOs, at least I thought was my CEO, so thanks for that. But one remark on the farmer responsibility. As such, I would love to be considered as someone that has some social responsibility. And this is something that was missing in the presentation. I would love to emphasize this issue. Because we are not here just to suck the money of this country and to sell it to the United States or England or some other countries. We are partnering with the local society. And we have responsibility for society, and we have to emphasize it in any discussion that we have with government, with payers, and with physicians. Thank you.
Lovely, lovely. I work for all the CEOs. They're on my board, so I view them all as mine. But we have him in common. Fully agree with you. And in fact, as part of this IMI, and you'll hear this tomorrow, the whole engagement in IMI in these things is also recognition from the industry that we need to make sure that our research priorities match society's expectations. So it's both that we behave well on the ground, and it's also that we actually align our research priorities. Now, if we have a problem with that, if we're not doing enough of research on antibiotics, for instance, then we have a problem. Then we have to discuss policy solutions. So I'm with you, and I'm glad that this is sort of permeating the industry these days. Now, comment or question. Oh, okay, let you know.
Okay, just one comment. If we take your logic for this country to its conclusion, your advice might be that they should start CROs and CMOs and all of the auxiliary aspects, because it's taken other places 50 years to really establish the ecosystem for innovation. So in a place where education is prominent, where technology is available, where good communication exists with the public, I think the small entrepreneur in academia would be better, in my opinion, better off to start a CRO and let that develop as it may, and see where that goes, because the penetrance into the market is easier than doing the full marathon of trying to get your own innovation all the way up to meet demand of the marketplace.
No, I basically draw the same conclusion in my previous meetings and trips, is that this is one area. The other, of course, is biologics, where you have a history and they have products, and I've heard about the FDA approval now for the Teva product. It's great, you know. That's something. So build on that, try and expand around that, you know. There's a lot of interest in biosimilars. Basically, all my companies are moving to biosimilars as well. So that's something to build on. Okay, one more question.
Thank you. Speaking about IMI, you said, and I would be a little bit controversial to have your reaction, because you said that IMI, it is a 9 pharma who decided to work together, but they don't work together in IMI. They work with everyone aside, with universities or startups. And there is a big, so it's just to get the 2 billion from the Commission. There is no work between Sanofi or others. It's just to.
There is.
Just because. And the problem, the main problem for the IMI till today was the policy, the IPR policy. Will be a little bit which take out from the universities right for license and also from the startup. So what will be in 2020?
Well, I don't think the IP policy is going to change much. I acknowledge that we don't have fully equal partners in the collaboration, right? So if companies are entering a project with what we call their assets, so their molecules, they're very good at patenting, we're experts in patenting. But we may join then academic groups that actually have knowledge which they've not patented. And of course what then will happen is that if this knowledge becomes more documented, suddenly it gets patented in the collaboration and then everyone's owns it. So I think the solution to that is that universities have to be much better in firming up their intellectual property rights before you engage in these programs. I don't think there's anything wrong fundamentally with the IP policy. I do think absolutely that the companies are collaborating. I see this in front of me how they collaborate. But the whole idea is not that you put people together in labs. The whole idea is this, and I give one example is new meds, and I think many of the calls in the future will be like this. It's about pooling knowledge. So with new meds, this is coming out of Copenhagen, where Copenhagen University and a couple of companies, Lundbeck from Denmark takes the lead, but there's a couple of companies. They pooled all their phase 3 clinical trial information from clinical trials, plus that we have a fair degree of genetic information and bio samples and so on. That's been put in on depression and schizophrenia, trying to understand this disease and heterogeneity. And that's working together. The companies are doing that, and when the output of this will be for everyone's benefit, then everyone will go away after this call and say, okay, now we know how we're going to target, and we can compete with one another. It's not that we're trying to create one company for the world. No. These guys we want to compete. We think competition is good. Competition is healthy. But that shouldn't stop you from collaborating when that makes sense. So I think, no, I'm very optimistic, and I think we had a tough, maybe you were part of it, you have had first-hand experience. The people I talked to say it was very difficult to get going. We've learned a lot from the first 2 years of teething problems with IMI. Now, look at the calls coming now, and the things that are being prepared. And you will find that they are both better designed and of really good quality. For instance, on antibiotics, we have potentially 400 million euros to spend on developing new antibiotics, because there's a market failure. No one wants to develop any antibiotics, so we have to do something about it. And the companies are pooling what they can. So I hope you can attend the session tomorrow, and you can challenge Michel Goldman, and he will probably be better than me explaining and defending. So thanks for the question. And with that, I think we have to draw this to a close. Yes, and I wish you a good continued meeting, and I will probably see some of you at the healthcare forum, which is organized by our association in November. Okay, thank you very much.